now invite Dr. Samir Pagad for his talk on PCSK9 inhibitor.
Good evening, everybody, and thank you, sirs, for the kind invitation, Dr. Sharma, Dr. Gupta, and Milind. I'm going to talk about PCSK9 inhibitors, pro-protein convertase, subtilisin, kexin 9 inhibitors. I don't think most of us would try to remember this full form also, but that's what it is, PCSK9 inhibitors. And these have come to vogue recently in the last few years in our clinical practice. It's worthwhile knowing that these molecules exist. The first question which comes to our mind is, just having seen the previous talk, we already have enough molecules. Do we really need more drugs for lipid lowering? How low do we really want to go? Do we really want to reduce the LDL even further than what we can achieve with the statins, with the bempedoic acid, and with the ezetimibe? And that to a parenteral drug. I'm sure all of you know that this is a parenteral drug, subcutaneously given, and so costly. So do you want anything like that actually? And that's the basis of my talk today. We'll try and see whether there is any evidence for it or any need for this kind of a drug. So we all know, and the previous speakers also mentioned, that there is something called as the residual CV risk remains, even in those receiving high-dose statins or high-intensity statins. So we have these Prove It to Be 22 trial, IDEAL, TNT, all of them were moderate versus high-intensity statins. Now with high-intensity statins also, there were patients experiencing major CVD events close to rates of 20, 12, 8%. So still there is some scope for improvement. How much should we reduce the LDL? Now, there is enough data to suggest that absolute LDL-C lowering is related with relative risk reductions in cardiovascular events. So this was a 14 trial meta-analysis which showed that 1 millimole, that equals to around 40 milligram percent reduction in LDL-C, was associated over 5 years with 23% reduction in coronary events, 21% reduction in vascular events. So every millimole you reduce, you're going to reduce your event rates. So that is again important. What is the cumulative LDL-C effect? So if you see these diagrams closely, so this is familial versus non-familial hyperlipidemia patients. So this is the homozygous familial hyperlipidemia patients, and there you see the threshold for having a coronary artery disease is around 12.5 years. So around 12 years, homozygous familial hyperlipidemias usually will have a coronary artery disease, and we all know that. Whereas if you see a non-familial hypercholesterolemia, the cumulative LDL is supposed to be 160, and that is achieved at around 55 years is the general age when they have their first coronary artery event. So when you go to the without familial, that is heterozygous familial hyperlipidemia, so depending on where you start your statin, so if you start it at around 10 years, if you start it at around 25 years, depending on that, the graph will change and the age at which the first event occurs can be delayed. So what it says is, you need to start the statin early, especially in this heterozygous familial hypercholesterolemia patients. The previous slide showed that every LDL cholesterol reduction is important, and before that we realized that remnant risk still remains in spite of all the drugs which we currently have. So that is the reason why we have these molecules. So existing therapy does have certain limitations and challenges, and that is that in spite of ezetimibe, statins, and the bile acid sequestrants, all of them usually come with either poor tolerance or some amount of remnant risk. And that's why to feed this unmet medical need, we needed a potent, effective, non-statin agent that will reduce the LDL-C and reduce the cardiovascular risk. So that's why the indications were high-risk patients who were unable to achieve the LDL-C reduction, patients with heterozygous familial hyperlipidemia, and patients who could not tolerate the routinely used drugs. And that's where PCSK9 inhibitors find finds its role today. What is PCSK9? It is a enzyme which is secreted by the liver into the plasma. And what does it actually do? So if you see this, this is the PCSK9, this is the LDLR receptor, and this is the LDL molecule. So what exactly happens is, it's important that we understand this so that we can know the pharmacology better. So on the hepatocyte cell surface, when the LDL is attached to the LDL receptor, it gets endothelialized inside, it gets clarithrine associated vesicle forms, and the LDL and the LDL receptor is taken up by the endosome, and in that acidic environment, there is lysosomal degradation of the LDL, and the LDL receptor is again recycled back onto the hepatic cell. When it gets recycled, it becomes active again to take in more LDL particles from the circulation. So that is how your LDL levels come down. So this kind of recycling of LDL receptors is the mainstay of mainstay where the LDL particles from the circulations are taken up by the liver. So what happens when you have a functional gain of PCSK9? As I said, PCSK9 is secreted and it also acts on the LDL receptor. It attaches to the LDL receptor. So you have a combination of LDL receptor and the PCSK9 molecules, which is again taken up by the vesicle, endosome again in the acidic environment. Here what it does, because the PCSK9 is attached to the LDL receptor, the whole thing gets degraded. And because all of that gets degraded, you do not have more LDL receptors to be circulated back to the cell surface. So when you have no LDL receptors on the cell surface, the LDL taking away of LDL from the circulation is reduced, and that's why your LDL levels go up or remain up. So this is the mainstay of mechanism of how PCSK9 acts. And when you have a PCSK9 inhibitor, this degradation is inhibited, and therefore the LDL receptors can be recycled again. And that is how PCSK9 inhibition acts. This is the mainstay of therapy because we have PCSK9 inhibitors and many other molecules, as the further talks also will be there, which are aiming at this particular mechanism of action. So you have the proprotein convertase subtilisin kexin 9 inhibitors. These are fully human monoclonal antibodies. When they started, they came out with total mouse or chimeric antibodies which had a lot of immunogenicity, and because of the immunogenicity they had certain adverse effects. So with this recombinant DNA technology, now you have fully human monoclonal antibodies which are not rapidly clear and hence can act for a longer time and can bypass liver and kidney metabolism and thus create lesser side effects. The pharmacokinetics, bioavailability 72%, Tmax is 3 to 7 days. So it takes about 2 to 3 days for the effect to come up, and the steady state is achieved after the couple of doses. So that is how it basically acts. What are the clinical efficacy? We saw that LDL particles can be removed. As with, we need other lipid parameters also to be acted upon. So evolocumab or the PCSK9 inhibitors have significant effect on the ApoB, which reduces by 40 to 50%. Lipoprotein A, which is the main problem in today's lipidology, that is also reduced by 20 to 30% with this PCSK9 inhibitors, and a modest increase in the HDL-C levels. Coming to the evidence, what do we have evidence? Knowing the pathophysiology and the pharmacology, what do we have regarding evidence? Regarding the evidence, we start with the plaque reduction. So we had the Glagov trial where the coronary angiogram and baseline IVUS was done, lipid stabilization, randomized into a placebo versus a PCSK9 inhibitors, and end of the study IVUS was studied, and what we saw was the percent atheroma volume reduction was significant, statistically significant in the statin with evolocumab versus statin monotherapy alone. So plaque reduction definitely reduced. Indirectly also LDL reduction is related to regression of the plaque. Coming to the Fourier trial, again this was a relatively old trial where evolocumab and statin combination versus placebo and statin monotherapy reduced the LDL to more than 30 mg% along with cardiac event reduction 2, which was a 2-year follow-up. But today we have data for long-term follow-up. Now we know that LDL reduction up to 30, 20, what is the safety of this? That's the question which comes to our mind. Getting LDL as low as possible, but are they safe enough? And to answer that question, we have the Fourier OLE, or the open label extension studies, which was part of the Fourier study only. The same 27,000 odd patients were studied for in the Fourier trial, but here in the OLE extension trial, 6,000 of those patients were taken and randomized to basically evolocumab versus matching, which is this is the original parent Fourier trial, but in the Fourier OLE extension, what they did is both of them were open labeled and continued to have evolocumab for around 5 years. So totally you have close to 7.5 years of data where you can know whether this kind of LDL reduction, is it safe or not. So this is how it was, first 2 years, 2.5 years, placebo versus evolocumab, and then it was an open label, everyone received evolocumab for the next 5 years. What did we see? Safety data. There were no serious adverse events which were anything statistically significant in the evolocumab phase Fourier and OLE. So this diagram tells us, the dark red color bars tell us regarding the delayed or the 5-year or 7.5-year follow-up of the safety data. So no difference in the safety regarding hemorrhagic strokes, injection site reactions, drug relations, and muscle-related events or new onset diabetes. Efficacy was definitely much better when you give the evolocumab, the blue line and the red line, the differences of the Fourier trial. So the blue line showed placebo and then evolocumab, whereas evolocumab and evolocumab. So these two arms, there is a clear indication there is a significant reduction when you start evolocumab early rather than in the delayed arm. So what does it show? Primary endpoints, secondary endpoints, CV death, all of that showed significant CV reduction. That tells me that earlier you start getting the LDL lower, the better it is in the long-term events. Getting an LDL as low as 30 mg% is safer in up to 7 to 8 years. So this was the conclusion of the Fourier OLE trial. What about early in acute coronary syndrome? So LDL modification in acute coronary syndrome, we understand that the small and dense LDL is what is present in the acute coronary events. We have data regarding that, the EVOPAX trial, which showed that significant reduction, attainment of the LDLC, target LDLC, which was less than 70 during that time, was achieved with evolocumab with statin versus only statin. So that was 95% people attained the LDLC as per target levels. There was a Chinese data trial which also showed that early initiation during the acute coronary syndrome had definite better primary endpoints compared with the controlled, and clinical outcomes were up to 18 months here.
Sorry, Dr. Samir, you have to conclude.
I'll finish it, yeah. So there are some pleiotropic effects which I will just, so this is what we finally arrive. PCSK9 inhibitors finally in clinically are indicated for high-risk patients who are unable to achieve LDL-C levels with heterozygous familial hypercholesterolemia, and those who are unable or to tolerate or cannot be prescribed the routine statins which we have. Along with that, we have newer things on the horizon, inclisiran, which is going to be the next talk. We have oral molecules. So this was a parenteral, that was a challenge. So oral PCSK9 inhibitors, phase 1-2 trials are there. Then there is a CRISPR DNA-based technology where the PCSK9 itself is silenced. So that is the technology which is trials are going on for that. And we have something called as the anti-PCSK9 vaccine. So what evolocumab or PCSK9 inhibitors do is a passive vaccination. So there is active vaccines which are being thought of, or AT04A, which is undergoing phase 1 trials. Thank you very much, and I'll end my talk here.